right, thanks.
Let's get started. So, hi everyone. My name's Josie Acuna. I'm going to be giving this lecture along with Dr. Shrikar Adhikari. We're from the University of Arizona in Tucson. The title of our lecture today is Getting Back in the Game, Using Point of Care Ultrasound to Enhance Your Sports Medicine Practice. So let's get started. So ultrasound's been a rapidly developing area of sports medicine. It has a lot of different applications. It can be used in clinic for rehabilitation purposes, in the training room, on the sidelines. So we typically think of it being used for diagnostic purposes, which is what I'm going to be discussing in my part of the lecture, but it can be used for treatment purposes as well, as you're going to hear a little bit later. Let's go over just our brief objectives for today. We're going to discuss how to incorporate high-yield ultrasound applications efficiently into a variety of scenarios encountered in sports med, demonstrate awareness of the use of ultrasound in the management of traumas, MSK injuries, pain management procedures. We're going to recognize the benefits of using ultrasound in the management of these patients, especially in a resource-limited setting, like if you're at a major athletic event. And then understand some of the pearls and pitfalls of ultrasound applications in the sports medicine setting. I figured the way I would present is just going through some various cases that'll get you used to different settings and focus applications. So the first case was a patient that I had. He was a 29-year-old male, athletic build. He was in shape. He was a military guy and he was playing soccer over the weekend. He describes a completely non-contact injury where he thinks he stepped wrong, twisted his ankle, but then he heard what we know of now as this like classic pop, followed by extreme pain. So he comes to the ED, he's completely non-weight bearing, really, really tender over the heel. So just based on this mechanism and his exam, we had a really good idea of what was already going on, but we wanted to confirm, we wanted to give him an answer. So we brought out our trusty ultrasound machine and we scanned over the heel. So here's what you see. Now, in case you're new to ultrasound, I wasn't able to look to see who's here, or you haven't done many MSK injury studies, over here to the right, just note that I have where the probe is going to be placed for evaluating the heel. So we have a long axis view here on the left of the Achilles tendon. If you can, it's really nice to try to get the patient in prone position with their foot hanging off the bed. I realize that in most settings, especially if the patient's in a ton of pain, you're not going to be able to get them on their belly so you can scan their heels. So this is the ideal position, but you can get some nice images even if you don't have them prone. You do want to use the high frequency linear transducer because this is a very superficial structure you're going to be evaluating. And as most of you probably already guessed, this is a Achilles tendon rupture. A complete rupture of the Achilles is going to be characterized by just total disruption of the normal pattern of parallel fibers in the long axis. And often you can visualize the retracted tendons. Let me see if you can see my mouse. You can visualize the retracted tendon ends here. Remember that this tendon arises from the gastroc and soleus, and then it inserts on the posterior aspect of the calcaneus. You really want to make sure that you're scanning all the way through from the very bottom of the heel, almost all the way through to the mid-calf. Most of the ruptures are going to occur at 3 to 6 centimeters posterior to the calcaneal insertion. And that's just because this is where the cross-sectional area is the smallest and you have some hypovascularity here, but make sure you are scanning all the way through. Oops. So let's compare this image to the normal contralateral side that I have here on the left. And I always do this just so you can appreciate the normal appearance of tendon and really get an idea of how severe the injury is on the other side. Again, this is a view of the tendon in long axis, and notice how different it looks. It's really echogenic. We see these multiple parallel organized echogenic lines. Can't find my cursor. Not surrounded by any sort of fluid. And then on the right with our ruptured tendon, we see once again complete distortion of the linear fibrillar structure. And it's not nearly as echogenic, right? It's almost even a little hypoechoic. So you also want to make sure, my favorite the thing to push that I'll be saying in my entire lecture is that you want to make sure you use dynamic sonography, especially for evaluating any tendon injury, not just the Achilles. Like we see here in these clips, we can tell that we have a little bit of this muscle, a little bit of muscle movement here. This patient really couldn't move his foot at all. So I actually did some passive dorsiflexion, plantar flexion to really get the view I needed. And this is what is going to help you differentiate a full tendon rupture a full thickness tendon rupture versus a partial rupture. So as I had the patient slightly dorsiflex, plantar flex at the ankle under visualization, I was able to see one tendon separate from the other. And so I was able to diagnose a full thickness rupture. In contrast, if you do see some continuous movement of the tendon across the site of a potential rupture, it more than likely indicates a partial rupture because you still have some of those intact fibers that are helping that tendon glide along. Oops. Other findings that might come along with a tendon rupture is a surrounding hematoma, some posterior acoustic shadowing at the margin of the rupture. But another thing you can look for is herniation of Kager's fat pad into the tendon gap. This is something people probably don't often look for. Usually you just look for the hematoma or the actual tends coming away from each other. But this is just more for style. It can be really helpful in some exams are a little more obscure. Kager's fat pad is also known as the pre-Achilles fat pad. It's this lipomatous structure, and here's an example of a normal one here, located in the posterior ankle joint, and it's just anterior to the Achilles tendon. Again, this is a normal one. With tendon rupture, you can sometimes see this fat pad actually start to herniate into a tendon gap, and then that alerts you that there's something for it to herniate into. There's actually a gap in that area. Can even happen with a large partial rupture as well. So just keep this in mind during your evaluation when you're looking for some ancillary findings. Some few reminders just to convince you to incorporate this into your practice is not just Achilles, but for any tendon. The Achilles tendon rupture is just always a nice popular example. Is that any missed or delayed diagnosis of a tendon injury is going to can result in significant patient morbidity. And it's not always clear clinically, just like with our patient, he had a lot of edema. We really couldn't get him to do any of the physical exam maneuvers that we were hoping. So ultrasound really was our next best way to get him a concrete diagnosis. And then the sensitivity and specificity for ultrasound of the Achilles tendon rupture is 96 to 100% and 83 to 100% respectively. So that's pretty good. So you can do this exam with some high confidence. And then, like I said, always use dynamic testing and always scan the contralateral side. For our next case, so Shrikar and I are from Tucson, as I mentioned. We're surrounded by all these beautiful mountain ranges. So we have a ton of mountain bikers, most of which are likely our own residents and fellows, because that's just what ED docs do. But at one point, a lot of them, it's not uncommon to see these mountain bikers make their way to the ED at one point or another. So this next patient was another one of mine who told me he was riding the incinerator. That's this trail. It's a horrible name, and it really is an incinerator. It's not the first patient I had in the ED that came from this trail. So he mentioned it was his first time riding the incinerator, and then he also followed it up by he was new to mountain biking, which is not the trail you want to do when you're new to the sport. So you can probably guess what happened to the poor guy. He actually crashed at one point naturally. He was wearing all his gear luckily, but he was able to break his fall with his left arm. And he came in with this exquisite tenderness over the triceps. While he was waiting to get room, they had performed some just basic x-rays of his upper extremity, and no fracture was seen on the preliminary read. But he seemed like a pretty tough guy. So when I could barely get him to range his arm, and he really was just in a ton of pain, he's diaphoretic, it really hurt. I knew there was something else going on, other than just a slight contusion. At the same time, I didn't want to keep him waiting for hours for advanced imaging in the emergency department, because that's kind of the wait time we had in our department at the time. So I chose ultrasound. We put the linear probe over the posterior aspect of the arm, over the triceps, both linear and transverse. And it was really helpful to actually have him point out the area of the most intense pain. Let's take a look at what we found. So this clip on the left is just what normal muscle looks like. This isn't our patient. Normal muscle is going to be relatively darker in appearance. It has this low echo intensity. And in the longitudinal plane, the larger picture, we see the fascicular structures are very visible, very organized. So we look for linear or triangular structures. And then in the transverse plane, the smaller picture down here at the bottom, the muscle will have more of a speckled appearance. And again, it's moderately echogenic. Our patient on the right looks completely different, right? Very disorganized. This again over the area of maximal tenderness that he was able to point out for me. So just note the complete fiber disruption. It's characterized by a well-defined hypoechoic, almost even anechoic regions of fluid that we see right here. And all of this is consistent with the muscle tear that I had expected in him. At the same time, we also wanted to make sure we weren't mistaking all of this for a tendon rupture, or that there wasn't a muscle tear as well as a tendon rupture that occurred, because this really seemed like it was quite the fall. So make sure when you do see a sign of a muscle tear, you also evaluate all of the large tendons in that area as well. So you made sure to identify the triceps tendon all the way down to the olecranon. As I showed you in that earlier picture of a normal looking tendon, this one's nice, echogenic, very linear. Not that this is a normal image by any means, but there's certainly a lot of surrounding fluid. But what we could say is that we didn't see a complete tricep muscle rupture. Because again, he wasn't able to really range that arm at all. So we didn't know if this was just because of edema, pain, the muscle tear, or if it was actually a ruptured tendon. So another thing we considered in this patient, he didn't have one of these, but another thing you want to consider when you have a suspicion for a very large contusion is that they have an intramuscular hematoma. So I have a couple examples here to show you from some other patients. They can be seen with really severe muscle contusions. Now, note that these appear a little more well-defined. They almost appear to be like encased within the muscle. They're a little more anechoic and hypoechoic than some of the fluid we saw earlier in our patient with the muscle tear. Early on, I think the best thing to know about these is that early on in the first 24 hours, these hematomas appear heterogeneous. You see both hypoechoic and hyperechoic parts to it, as you can tell right here in this image on the right mostly. And this can be appreciated up until 24 hours. And then after that, it starts to become a little more homogeneous, a little more just completely anechoic as the blood products start to coagulate. The one on the left here was just the large calf contusion. And then the one on the right here is actually really, really large. It didn't even fit within the footprint of the probe. This was a large rectus sheath hematoma. So keep these in mind too. I won't bore you too much with the physics behind this, but I have to talk about anisotropy a little bit. This is a common pitfall when performing muscle and tendon evaluations. So the linear configuration of these structures that we just talked about, they make it susceptible to something called anisotropy. Anisotropy is an imaging artifact. It causes really highly ordered tissues like muscles, tendon, ligaments, everything we just talked about, to have this hypoechoic, almost anechoic appearance, which, like we just discussed, is also the appearance of a tear or a rupture. So sometimes this artifact, if you're not aware of it, can be mistaken for an actual injury. And you don't want to overcall something. So this artifact, I promise this is only a couple sentences of physics. This artifact occurs in the ultrasound beam, is not directed completely perpendicular to the structure you're examining. So in other words, this effect makes a muscle or a tendon appear nice, bright and white when it runs at 90 degrees. But when that angle is changed, it starts to appear a little darker, a little more hypoechoic. And all you need to fix this is just, as you might already do, is completely fan through the structure you're imaging. You might just need some careful probe repositioning to ensure that the apparent hypoechoic anechoic region is due to artifact rather than an injury. Just change the angle of your probe and then look to see if that hypoechoic region persists. I have a really quick example here on the right. This one's pretty subtle, but if you look at the top image of this tendon, we see this, I don't know if you can see my marker, this anechoic region. And then just with a slight angle of the probe as you're fanning through it, you see this anechoic region, the color of it actually changes and now it looks a little more like the surrounding structures. Let's move on to a little more subtle case, not something as exciting, but very common. This is a patient that will come into your clinic with chronic shoulder pain. We see this in athletes who perform repetitive motions such as throwing, serving, swinging a golf club. We also see this a lot. We have a large retirement community in Tucson, so I'm seeing a lot of this recently with people who are playing pickleball, which is apparently all the rage. But it can predispose people to these little tiny micro tears and inflammation. So when a physically active type of patient comes in with a chronic or even subacute type of pain, one thing you're going to be naturally concerned about is a tendinitis, and we can evaluate this with ultrasound as well. Why isn't this playing? There we go. So when you perform an ultrasound of the shoulder, we come across this view of the head of the biceps tendon. This is where our patient came in and he had chronic shoulder pain going on for months already, just getting worse and worse. I mean, he was markedly tender right over this spot. Now, I'm the first to admit that a full ultrasound of the shoulder, at least for me, is pretty difficult. It's pretty challenging. And unless you're a sports med doc doing a number of these a week, they really do take some attention and practice to get good at them and to really diagnose something with confidence. But this view here, this particular view where you evaluate the head of the biceps tendon, is really one that I think anyone can do. This is the one view that I have down and that I like to start with. So the probe is placed in the transverse position just over the anterior shoulder, really easy spot to locate. And you visualize the most proximal portion of the long bicep tendon. And this is a spot between the greater tuberosity and lesser tuberosity of the humerus. So this tendon here on the left is in short axis, and we see that it's surrounded by this anechoic fluid. This is termed halo sign. I know some people hate that we make signs for everything, but that's apparently just what ultrasound people do. This is halo sign. This depicts tendinosis with an effusion within the sheath. If you happen to find this collection of fluid around the biceps tendon sheath, it should prompt you for further examination, because one thing you want to do is really differentiate this from a primary biceps tendon pathology, like a tendinitis, which it very well could be, versus a secondary finding from something a little more ominous, like a rotator cuff tear. So if I see something like this, if the mechanism doesn't really clearly fit, it really should prompt you to get a little more imaging. There's a bit more on some tendinitis. As I mentioned, it happens when somebody overuses or injures a tendon, but there's different changes sonographically over time. Usually we're going to see, and it's going to be different, obviously, based on what joint you're looking at, elbow, knee, shoulder, hip. But the early changes for tendinitis, you're going to see tendon thickening and can be very subtle, contour change, echo texture change. For early changes, this is really why you want to look at the contralateral side. And the more progressive changes, when the disease is progressive, looking for, again, further tendon thickening, loss of that normal fibrillary pattern, hypoechoic heterogeneity. And you also want to start putting Doppler over it, even when this is early on, to see if you have some neovascularity. It's typically when you start to see the loss of the fibrillary pattern and the neovascularity is when patients are going to start to be more symptomatic. And here's just a couple examples we have other than the biceps tendon, because I know that's not incredibly common area that people are going to be scanning. On the left, I have a patient with tendinitis of the Achilles tendon. Couple classic findings. We do see that it's enlarged, thickened tendon, putting color over it. We do have a little bit of microvascular changes. And then on the right, it's a really fun one we found a few years back. This is a infrapatellar tendinopathy. This is a long axis of the infrapatellar tendon. It demonstrates a really thickened proximal part. Again, if you were to compare this to the tendon on the other side, as it starts to kind of insert on the patella, it normally is not this thick at all. And then we put some color Doppler mapping that is showing a lot of increased vascularity around the tendon. And then what I really like about this clip in particular is you can see the underlying fat pad. As I've learned, fat pads become very, very exciting, for lack of a better word, in sports medicine. So you see this underlying fat pad, Hoffa's fat pad, which is really prominent and edematous here. And I would imagine if you compared this to the contralateral side, it would not be this prominent. So this can be a sign of just inflammation of this fat pad, or even fat pad impingement syndrome. All right, so our next case is a patient that is injured on the field, on site at the actual event. You're looking for a quick way to just determine the severity of the injury. You want to decide if immediate action needs to be taken on the field, if you need to immediately transfer them to a hospital, or if you can just have them waited out on the sideline and get them evaluated in clinic later. In essence, it's really how you can assist, ultrasound can assist in a quick sideline triage. Sorry, that's not a video. So our first case is a patient that was tackled during a game, landed directly onto the shoulder, and now he's holding his arm on his side, he's unable to move it, and you fear a shoulder dislocation. And with ultrasound is really a truly rapid way that you can confirm your suspicion. So you can grab either the high frequency linear probe, like we've been using for all our other studies, but in this case, other people like to use the curvilinear probe as well. Both of them will work for you. It really depends on patient habitus and personal preference. I usually like to use the curvilinear probe, but I've used both and they both work just fine for me. You want to position a probe on the transverse orientation behind the shoulder. And if you can, palpate the scapular spine and put the probe just directly on top of it. And then you want to move that probe laterally until you're starting to see the glenoid, and then just a little more until you have a good view of the humeral head. Notice here how this humeral head fits nice and snugly into the glenoid fossa. I want you to remember this image right here and keep it in mind as we show you another view of our patient that had the injury. All right, so here's an ultrasound of our patient's shoulder. Once again, here's a glenoid fossa, but in this case, the humeral head is not fitting snugly in the glenoid fossa like we saw in our last picture. We see it further away in the far field of the screen, and it's away from the probe. So remember, if the probe's on the patient's back and the humeral head is away from it, this is an anterior dislocation. Conversely, if you were to see the humeral head in the near field, closer up here, closer to the probe, more posterior to the back, it's a posterior dislocation. For people who are learning, especially some of your residents who are a little more new to ultrasound, I think that this was something that just conceptually I had a hard time wrapping my mind around. It's nice to just demonstrate it over and over again, and eventually it starts to make perfect sense. But you have to know your anatomy, you have to know the glenoid fossa, humeral head, and the kind of the dynamics of a posterior anterior dislocation. So what's the data on this? I want to get out of this. The data is actually really great. There's a recent study, 2020, by Secco et al. Entitled Musculoskeletal Ultrasonography to Diagnose Dislocated Shoulders. This was a prospective study on adult patients who had suspected shoulder dislocations. They came into the ED, and the primary outcome was just diagnostic accuracy of point-of-care ultrasound for shoulder dislocation. The POCUS studies were compared to x-rays, and POCUS performed great. I had 100% sensitivity, specificity, positive predictive value, and negative predictive value for diagnosing shoulder dislocations. It's a nice, quick, easy read. I think this is one that is very much practice changing, especially if you have a hard time just getting plain films in your emergency department. You really want to improve your throughput time. So I put the QR code to this article here. Another injury sustained from a really similar mechanism of being hit on the shoulder or landing directly on the shoulder is an AC joint, particularly a separation injury, widening of that joint space, sometimes with dislocation of the clavicle. This is another easy one that ultrasound can help you diagnose. So the clavicle is usually identified sitting slightly higher in position than the acromion. For this scan, you want to use, again, a linear high frequency probe. You want to place it along the long axis of the clavicle. So it always helps if you can palpate the clavicle first. And you want to measure the joint width. Now this one, it's really important, once again, that you compare this with where you're measuring. You want to also measure in the exact identical position on the opposite AC joint. And that's because the anterior aspect of the AC joint is wider than the posterior aspect. So if you're not measuring in the same spot, again, the AC joint is not going to be the same width all the way through. So you really want to make sure you scan the corresponding region of the asymptomatic side as well. And generally, if it's greater than 6 millimeters, and if the AC joint is greater than 6 millimeters in space, it's considered pathologic. This one's definitely, that I have here, it's definitely greater than 6 millimeters. We actually see a little bit of a fusion here as well. Lastly, we will talk about fractures. A POCUS exam is going to really expedite the diagnosis and treatment of a long bone fracture. And clearly, a prompt diagnosis of a fracture is important, especially in cases where a fracture is associated with significant neurovascular injury. So this is another one that you could potentially perform on the sideline, and it's like this person, really needs to go to the hospital right away, because obviously, in an athlete or in anyone, neurovascular injury can be very scary. So studies have shown that a long bone fracture can be excluded with a really high degree of confidence using POCUS. And I find that it's actually not too difficult. You're really just evaluating for cortical irregularities, displacement. And it's always helpful if it's a very acute injury, if you have a surrounding hematoma or effusion, that's a nice clue to know where to start scanning. So I just have a couple examples for you. This is somebody that fell directly onto their knee. They had immediate pain, non-weight bearing, and putting the probe directly onto the very obviously deformed patella. It took just a second to get this view. This is like really the only view we need to say, hey, this is a very obviously completely fractured patella, comminuted. So very fast, very obvious, only took seconds. And then on the other extreme, we have some that are a little more subtle. This is actually performed recently, a couple months ago, by one of our fellows, so I have to give him props, even though he's not online today. But this is a great example. This patient had an injury to the elbow, difficult with range of motion. An X-ray was performed that didn't find an obvious fracture. Radiology read said, well, we do see a small effusion, so maybe there's a fracture. Get X-rays in a few weeks and maybe something will show up. So we decided, and they also noted in their read, usually when this happens, it's usually the radial head. So our astute fellow took the probe over, went over the patient's radial head, again on an area of maximal tenderness, and found this very small, but obvious, it's definitely a cortical irregularity. So when you're looking for cortical irregularities, just make sure you're following this really bright hyperechoic line all the way through. And this is another one where we looked at the contralateral side. We did not see it there. We were able to tell the patient with more confidence, this is a radial head fracture. We need to get you in a splint. We need to get you orthopedic follow-up. So it can be done. I mean, this is, again, one of our fellows just decided to, he really hadn't scanned that many elbows, to be honest. So only after a few he was able to do this with high confidence and get a nice diagnosis. So you can do it too. That's it for my section. Next up is Dr. Adhikari. So I'm going to stop sharing my screen with you all. If you have any lingering questions, comments, I don't know how these work. If you have time at the end. But I also left my Twitter handle up here for all of you to comment, ask questions. I'd be happy to talk. Thank you. Let me stop sharing so I can give Shrikar the room.
Actually, if you have any questions for Josie, please go ahead while I'm figuring this out, how to share here.
More of a comment, Josie. I literally had a patient yesterday that fell walking our dogs, and she's having extreme pain supinating her arm.
Yeah.
And ortho ended up sending her to CT, and she had a radial head fracture that they couldn't see on X-ray.
Yes.
So had I just put the probe on her, I may have been able to spare her some radiation.
He actually motivated me to look at it more, because I'll be the first to say I don't do a lot of elbow. And I think it's probably because it's just a weaker point for me. But he had only done a few himself, and he found this pretty quickly. So
That's
I'm
awesome.
motivated by our fellows' optimism. So I'll definitely be doing more. Plus CTs take forever at our place too. So I feel horrible making someone wait 3 hours to diagnose something I could find quicker.
Yeah, absolutely.
I have another real quick question. I'm a med student at MUSC in Charleston, and I've been doing kind of ultrasound research with the ED there since my first year, something I'm really passionate about. But I know with like the way ortho works at our institution is, even if like they find something via POCUS in the ED, they still want those scans. How can we kind of avoid doing that? We're already finding it on ultrasound. How can we kind of get their confidence up, in the, ability of the ED to make those diagnoses?
I mean, that still happens to us. It's hard. I think that it's more just being persistent about it. Sometimes we will be right in front of them. We'll show them our ultrasound and they'll say no, but they still need to go to CT. And then when they come back, we kind of, very nicely say, oh, so it looks like that was a radial head fracture, just like our ultrasound showed. This has happened with ortho and a few other ultrasound related applications. But I think for us, it's really just about persistence and getting that relationship with your colleagues. It's hard for you because you're in residency, so you may go somewhere else in, a couple years or so. But especially now at my institution, I've been there about 5 years now. There's a few people that will finally trust my ultrasound, and it's hard that you have to play that game, but at the end, when they have confidence in your scanning and you're almost annoying about it, scanning every patient and trying to show them what you found, it eventually, I feel the fight. It's hard. You're not the only one.
So Lauren, I think I would say certainly being in a place for a while works because you build a relationship, but more so than anything else, I think taking them to the room and actually scanning them real time and showing, just like Josie said, that applies to any other application, including OB and whatnot. So nobody trusts you on the phone when they actually walk into the ED. Let's go scan together and you will show. And I think you'll have, more success by doing that.
Okay, great. Thank you, guys.
Keep up the good fight.
Any other questions for Josie? If not, I'll get started. So my name is Srikar Adhikari. I'm one of the faculty in the Emergency Medicine Department at the University of Arizona. First, I want to thank all of you for joining this session. I also want to thank SAM for the opportunity to speak. Continuing with the talk, Josie covered a lot of diagnostic musculoskeletal ultrasound. That's actually the meat of sports medicine. I will see if I could give you like a big picture, not specific examples of other applications, ultrasound applications, not diagnostic musculoskeletal ultrasound. So these are my disclosures. I have a grant from EMF, and I also do some consulting for GE, Philips, and Wave. Let's start with the procedural guidance. A wide variety of procedures are done by sports medicine physicians. One of them is a nerve block. So ultrasound-guided nerve blocks could be used for like things Josie showed you earlier, like analgesia for fractures, or if you want to reduce fractures in the sidelines, or you want to reduce dislocations, joint dislocations, or you want to repair the lacerations in the locker room, or you want to remove foreign body, or in some cases, maybe even address chronic pain. So here is an example of an intercostal nerve block. The goal is to actually infiltrate the nerve block around the neurovascular bundle. The anatomy is the neurovascular bundle is in between the internal intercostal muscle and the innermost intercostal muscle. You may not see the innermost intercostal muscle consistently in ultrasound, but you will see the pleura. So here's a case where a patient presented with a rib fracture, a week into rib fracture, still having a lot of pain. So one of our residents performed this block. So essentially it was a color Doppler to recognize the neurovascular bundle here. And then obviously we can see that pleural line well. So with locating the neurovascular bundle, now we know exactly where we should be infiltrating. So you can see the infiltration on the right side, the bupivacaine. So again, I think it gives you really, especially if you have not done that many, it gives you confidence to perform these blocks where you can, it can increase patient safety and you can stay away from the pleura. The reason I showed you this specific example is some of you already know, but this was widely reported. Los Angeles Chargers had a quarterback, a veteran quarterback they just signed. And then it was in the news that he sustained rib fractures. I think it might have been the, not the regular season, preseason games. So right before, I think the game, he received a intercostal nerve block, and then he could not even take the field. So he had a pneumothorax. We don't know exactly the details, how it was performed, whether ultrasound guidance was used or not. We don't know the details about it. But nevertheless, he did had a pneumothorax, couldn't take the field, and the rookie quarterback took over the reins, and the veteran quarterback never saw the field and he was released at the end of the season. So it is actually a career-changing procedure. That's what he had done. I'm not saying, I'm not giving this specific example. In general, I think this particular blocks are routinely performed in sports. There was no systematic research done. However, when NFL physicians were surveyed, more than 50% of the NFL teams were performing intercostal nerve blocks, either for the acute fractures or subacute fractures. In some cases, about 40% of the teams were doing it just to get them back on the field. And you can see the magnitude of this problem and how ultrasound could potentially help on the game day. In fact, there was one study, not our NFL football, but Australian football. They actually used game day blocks. So where they use ultrasound guidance, it's a very small study where they wanted to see if they could comfortably play without pain, and also are there any complications from injections. So in this small study, they actually did well. They were able to complete the game without any difficulty, no complications, and some of them actually received blocks after the game. So certainly one of the applications where nerve blocks would make a difference, and I think ultrasound guidance could be kind of widely used in sports for performing nerve blocks. So besides nerve blocks, there was tons of joint procedures done in sports medicine practice, whether just aspirating the joint or even injecting the joint with steroids or PRP. PRP, it's almost becoming a business these days. So again, placing the needle in the right accurately in the desired location is what ultrasound, the beauty of ultrasound. So, and I know a lot of experienced physicians think they can do the joint aspirations or joint injections without ultrasound. I have seen over and over where the block wasn't successful, or I'm sorry, aspiration or joint injection wasn't successful, even in something like a knee. So I think ultrasound could make a big difference. So here's a review published looking at several studies, different joints, how the joints were injected. So just looking across the board, like shoulder joint, or subacromial injection, or AC joint, or even the biceps tendon injections in elbow and whatnot. So across the board, ultrasound guidance outperformed landmark in terms of landmark method in terms of accuracy. So it seems like based on this data, it should be favored. Ultrasound guidance should be favored for joint injections in sports medicine practice. Looking specifically at hip joint, that is something people get a little bit anxious. So there are 4 studies they looked at in the systematic review. Again, ultrasound guidance was shown to be superior to landmark method in terms of accuracy. As far as the knee joint, in terms of arthrocentesis, again, this is another systematic review. They looked at 9 studies, a bunch of patients, and they wanted to see the accuracy rate in between ultrasound guidance versus landmark method. Again, ultrasound was better in terms of accuracy and also having lower procedural pain scores, and more volume was aspirated with ultrasound guidance. And there was also decreased pain score 2 weeks after the procedure. And I remember a couple other studies where ultrasound guidance was used, even with the knee joint aspirations, operator confidence was much, much higher. And the attempts, and there were fewer attempts in aspirating the joint compared to landmark method. So ultrasound guidance it's favored over landmark method, and that is something advocated in sports medicine practice. Also here's an example where a patient with a shoulder dislocation seen in our ED, where a resident injected local anesthetic into the joint, and right after injection, a Cunningham technique was used to reduce the joint. Again, patient was very comfortable throughout the procedure. And the beauty of doing something like this is patient could be gone in a matter of an hour or an hour and a half after they hit the door in the ED. Or in the sports medicine world, that is something you can do quickly in the locker room without having to go through a lot of pain. And Josie kind of covered this. Again, ultrasound guidance could be used instead of x-rays pre and post, shoulder joint dislocation reduction. Here is an example of a shoulder joint dislocation where we have an anterior dislocation, and then after the reduction, you can see the humeral head aligned with the glenoid. So not only for nerve blocks, but also for joint reduction and also for joint aspirations and joint injections, ultrasound guidance could be extremely helpful in sports medicine practice. Besides all the procedures I discussed, there are a lot of procedures sports medicine physicians specifically do some things like tenotomy, fenestration, barbotage, meaning they aspirate all the calcific deposits on the tendons, and then they also do trigger point needle injections and tendon scraping. All of these across the board, I think ultrasound guidance has shown to be superior for these procedures instead of landmark method. All right, shifting gears a little bit. FAST exam. Well, if you think about FAST exam, we're all like thinking FAST exam, oh, it is typically used to determine which patients need operative intervention. And that is the purpose of the FAST exam. How is it helpful in the on the sidelines? So I would say, I think it would help the transition of an injured athlete quickly into the hospital system to avoid some of the bad outcomes. Again, I'm a big fan of NFL. I would skip a shift for an NFL game, although I didn't. So here is an example of Chris Sims was Tampa Bay Buccaneers quarterback. This was I think it was been a few years. And in the middle, he was taking several hits in that game with North Carolina. And I think somewhere in the second quarter, he got hit by Chris Jenkins. And I think he got sandwiched between two players. And somehow he managed to get up and continue to play and continue to take hits. So he wasn't pulled out of the game. And in fact, he went back in the third quarter and he had a syncopal episode. And then he continued to play. The exact phrase Chris Sims said was, "No bones and no blood. So I am allowed to play, and my coach is allowed me to play." So I played. And the bummer was they lost the game. But at the end of the fourth quarter, he really got sick. And he was immediately transferred from the locker room to the hospital. And he had significant hemoperineum. He received multiple blood transfusions. And his wife was even told he may not even make it. And then he went to operating room and he had a splenectomy done. Certainly, obviously, his career changed since then, whatnot. I'm not saying, I mean, it's one way, it could have been even worse for Chris Sims, to be honest with you. So something like this, to avoid bad outcomes, we have handheld ultrasounds all over. If Chris Sims would have gotten in the halftime, somebody would have checked. Maybe they would have pulled him out of the game. Maybe, I don't know, there's a chance he didn't need that splenectomy, who knows, because he continued to take the hits throughout the game. So there's really, I think, a sideline application here for ultrasound. I'm watching my clock, so just to make sure I don't go over time. So another application is mononucleosis. This is a significant time lost to the athletes because typically the spleen will enlarge anywhere between 2 to 3.5 weeks. And then it can go up to like 30% increase in size, but it's hard to predict who has splenomegaly, and also the size of the spleen is a little different based on the height and males versus females and whatnot. Again, ultrasound could potentially guide the sports medicine physicians to direct how long they need to be out, potentially decrease the time lost for the athletes. Pneumothorax, I don't even need to go through the examples, tons and tons, Tony Romo, whatnot, like tons of people got pneumothorax, and some of them continue to play. And unfortunately, fortunately, they didn't have bad outcomes, but this is something could end up really bad. So again, as you all know, very easy to detect with the sideline ultrasound. One other thing I want to cover is the focused echo in sports medicine. There are different protocols to provide early screening for looking for cardiac abnormalities in athletes. Here's a study done, Sports Medicine World, where they looked at septal wall thickness, posterior wall thickness, and the internal diameter of the LV, and there was good correlation when they compared it to the expert sonographer. Here's an example of hypertrophic cardiomyopathy. You can see the systolic anterior motion of the mitral valve here, where the mitral valve in the MO is actually touching the septum. There are several criteria that we use to diagnose this hypertrophic cardiomyopathy. You look for LV hypertrophy, systolic function, diastolic function, and also you look for septal wall thickness and the ratio between the septal wall thickness to the posterior wall. If it is more than 1.3 normotensive versus 1.5 in hypotensive. These are all the criteria routinely used to diagnose hypertrophic cardiomyopathy. And it also helps with risk stratification. Let's say the septum is more than 30 millimeter, there's a risk for sudden death. So people try to, maybe that is the person you want to pull them off the sports and whatnot. So, and a couple more examples here. Athletes, well-trained athletes are known to have increased aortic dimensions. In fact, AHA and the ACC recommend mildly enlarged, something like 40 millimeters in males and 36 in females. They recommend every 6 to 12 months of screening for aortic root. Typically, it is measured at the sinuses of Valsalva in diastole from leading edge to leading edge. Again, there's a study done sports medicine physicians doing this stuff and comparing with the expert sonographer. Again, there was good correlation. Also, IVC was explored for hydration status. Our group did a study here in Arizona Wildcats. They measured the IVC before and after the practice, and they correlated with the weight loss. And the post-practice expiratory IVC diameter was found to be correlated with the weight loss after practice. The last thing would be, it is not uncommon to sustain ocular injuries in contact sports, whether it's retinal detachment. Here's an example on the left side, and a retrobulbar hemorrhage with a guitar sign here on the right side, and also lens dislocation displayed here on the left side, and also vitreous hemorrhage. All of these injuries could be diagnosed immediately with ocular ultrasound. To summarize, a variety of ultrasound applications could be used in sports medicine practice in a wide variety of clinical situations. That could be something more than musculoskeletal ultrasound, and especially I think on the sidelines it would make a big difference. And as the technology is evolving, there's more handheld ultrasound, more AI. I believe it's going to only get bigger in sports medicine world. With that, I'm going to stop, and if there are any questions, I'm happy to take any questions.
That was awesome. Awesome talk. I don't know if anybody has any specific questions, but let's bring it to the sidelines.
Hey, my name's Andrew Smith. I'm a PGY2 from up PGY3 at University of Florida, applying to sports medicine fellowship. Got a question. I love the idea of the sideline sports ultrasound. Not something I've seen here, but I imagine it's on its way. Have you guys used the butterfly ultrasound much on the sideline? And is the speed fast enough to be able to?
When I was here earlier.
I have to say I don't have any experience with the butterfly. The few studies we've done with our football team, they were hydration machines. However, we do have a lot of experience with the Philips Lumify. So I can tell you most of the injuries could be detected with the Lumify ultrasound probes. But I can't speak for butterfly on the sidelines. I'm sure maybe Nick, they do a lot of sports medicine in the University of Michigan, can speak for that. If Nick is still around.
Yeah, I just was curious about the update rate on it. I've never actually used it, but with an iPhone and I just didn't know what the update rate was, if it was adequate enough.
I think I think what you said is very attractive, and I have no doubt. It's just not butterfly. There are numerous other handheld devices now. They have dual probes and GE and other companies and whatnot. So I think all of these devices, when they compete with each other, technology is getting better. Good for us. So I think it is going to be, in my belief at least, it's going to be common practice to have these devices on the sidelines.